Hey, Dr. Bob here, and we're continuing with the common diseases that I've been exposed to being a diagnostician in the emergency room for over a quarter century. And we left off after liver, gallbladder, and pancreas, working our way through the abdominal cavity, and I wanted to cover diseases of the digestive tract. We'll just kind of stick with the esophagus and the stomach, the small intestine, and the large intestine. And I'm going to just cover some of the basic diagnoses that I saw in my career, explain a little bit about what's going on so you have a better handle. The why is just for you to understand them because they could happen to you or a loved one. Most of these diseases are not terribly behaviorally related. These are just things that happen to people. I will discuss some of the predisposing factors. There's a few issues in there, people can do dumb things, and I'll make sure you're aware of this. So we'll start with the esophagus, a very common disorder, probably one of the most common that we see people running around with is called gastroesophageal reflux disease, GERD. This is a situation where the esophagus, the swallowing tube, where it connects to the stomach, is getting irritated by the acid within the stomach. This situation occurs because of an incompetent gastroesophageal sphincter. That's a muscular tissue that squeezes tight and only relaxes when we swallow to let food and water pass, and then squeezes tight again, so that this cauldron of acid that our stomach is with a pH of 2, the stomach has a special lining that protects itself from that acid. The esophagus does not. So we're trying not to let that acid bubble up into our esophagus. This is commonly associated with pregnancy for the simple reason of the stomach has more pressure in it as that baby's growing and that uterus is expanding in size. This can be associated with increases in visceral fat. So here again, an obesity-related disease, and all the things that we talk about with regards to obesity will pertain to this. Nicotine, it turns out, is a chemical that tends to relax the gastroesophageal sphincter and increases risk of incompetence and increased risk of GERD. So there are a few behavioral things that might impact this. We do have good medication that lowers the stomach acid and the pH and can alleviate symptoms, but these medications have side effects. I'm not without guilt in prescribing a lot of proton pump inhibitors, these medications like Prilosec and Nexium, now available over the counter. They have some negative effects. They do decrease bone density. Also, the class of medications called H2 blockers like Zantac and Pepcid can also reduce acid production, and both can be effective at treating this condition. But here again, lifestyle can have an impact. If you can stop smoking or using tobacco products, you can lose weight, you can have the baby, I guess. That's a condition that most people are somewhat aware of, and at the extreme event, it can become erosive and cause real problems, and chronic esophagitis does increase risk of esophageal cancer. Second big category of really serious esophageal disease is a condition called esophageal varices. It's one of the causes of upper gastrointestinal hemorrhaging. Upper GI bleeding is the term that we would probably say to a lay person, means that you're bleeding from the upper abdominal tract, stomach or esophagus. Lower is small intestine or large intestine. Varices are associated with increase in portal hypertension. I didn't use that word when I talked about, I discussed the process but didn't actually use the word. Portal hypertension means an increase in the pressure within the venous system that drains through the liver. And since the liver drains the gastrointestinal tract, that begins at the very lower esophagus and ends at the rectum. We see conditions when portal hypertension occurs, like hemorrhoids and esophageal varices, as these blood vessels, these veins in the esophagus get higher and higher pressure. Typically also if there's an associated loss of liver function and loss of those important clotting factors that we discussed associated with liver damage and produced by the liver for normal ability to clot our blood, then we are running a double-edged sword because these little blood vessels become like thin-walled balloons that can burst, and when they do, this is one bad situation. It's got a very high mortality. It's generally not painful. So when we see people who have upper gastrointestinal bleeding, they're vomiting red blood or perhaps pooping dark blood because it's been digested by the entire digestive tract because of all the time it's had to pass. We think upper gastrointestinal bleeding. Painless upper gastrointestinal bleeding is often caused by varices. The other cause of upper gastrointestinal bleeding is typically ulcers, which occur in the stomach. Generally, ulcers do cause discomfort. So we want to avoid esophageal varices. Again, two most common maladies that will lead to those are the two things that cause liver failure. Toxins, the number one being alcohol, and infections, those bloodborne hepatitis B and C, again, typically tied to behavioral things that we shouldn't do, like sexual promiscuity or IV drug use, transmitting these viruses to one another, which ultimately damages the liver. All right, so that kind of covers the esophagus, and we move down into the stomach. I alluded to ulcers. So lots of things can damage the lining of the stomach. Alcohol is corrosive to the stomach. It causes gastritis. It does increase risk of ulcer disease. But a very common medicine that many of us use, I don't advocate it at all after age 40. I no longer prescribe any non-steroidal anti-inflammatory drugs orally to patients over 40. Now, we'll get into this someday and I'll share a scientific study with you. But when you take an NSAID, you have a significant increased risk of clotting in one of your blood vessels. And it's very complex. We'll talk about it when we get into omega-3, omega-6 balance and all of that. But NSAIDs block the conversion of omega-6 fats to the inflammatory compounds that cause pain, and that's why they work. They also block the conversion of omega-3 compounds, fatty acids in our bodies that produce anti-inflammatory compounds that are obviously very important to our blood vessel health, and they can increase the risk of having heart attack and stroke, and it's been pretty well documented now by long-term studies. But their immediate effect on the gastrointestinal system is much quicker. So when you take a non-steroidal anti-inflammatory medication like ibuprofen or Advil or the competitor to Advil, when you take these medicines, if you take them on an empty stomach, they will probably land in the same place every time. Now, that non-steroidal anti-inflammatory medicine, as it's being absorbed, is going to have a lot of local effect right where it sits. And one of those local effects is that the prostaglandin blockage that these are known to do, they block the production of these molecules in our body. They do have an effect, obviously, that's why they work, stops the production of this mucin layer, that slimy layer on inside the stomach that protects our stomach lining from the acid that it's making. There's two cells in the stomach. One makes acid, the other one makes mucus. Well, you knock out this mucus production, and pretty soon the stomach's digesting itself. And eventually it will digest itself until it gets down into an artery, and then you will have an upper gastrointestinal hemorrhage from an ulcer. I have seen some pretty life-threatening gastrointestinal bleeds from ulcers. Generally, you're going to have epigastric pain. The epigastrium is this area right here. That's where your body thinks your stomach is. Occasionally, the pain might go into your back because if the ulcer goes that direction, it can cause some pretty catastrophic effects. And I have seen many cases where it was clear that a person, I've seen it in 20-year-olds, they've been eating ibuprofen like candy on an empty stomach for a week for some neck ache or back ache or muscle pull or whatever, and they darn near kill themselves. So when I do prescribe non-steroidal anti-inflammatory medications, which I do, particularly for moderate musculoskeletal pains in patients who I have no clinical suspicion for blood vessel disease, people that are less than 40, I tell them, very careful, don't take them with food, make them land on food, okay? So you eat some food and then you take the pills. Generally, like with ibuprofen, it's dosed 3 times a day. So I just tell people, look, eat your breakfast, take an Advil. However many you're going to take, no more than 800 milligrams 3 times a day, maximum dose. Eat your lunch, take the next dose. Eat your dinner, take the next dose. Probably pretty safe in that domain. Other things can cause ulcers: genetic predisposition, bacteria. This bacteria called H. pylori increases your risk of ulcers. That can be tested for. Generally, what we do when we suspect an ulcer, if the patient's stable enough, we send them home and have them put them on an acid blocker of some kind, perhaps both, a proton pump inhibitor like Prilosec and a H2 blocker like a Pepsid, and get them referred for upper GI endoscopy, EGD, as it's abbreviated. They put a camera down your throat, look at your stomach, esophagus, figure out where the blood's coming from. Okay, so that's kind of the major ailment of the stomach. I mean, I'm skipping stomach flu and all of that stuff. These are more serious conditions. Moving down into the small intestine. Probably the biggest problem that we see involving the small intestine is an obstructive process called small bowel obstruction. Again, a very, very uncomfortable situation. Episodic waves of severe pain. The bowel is kinked or blocked by some process. There are 3 predisposing factors, none of which usually the patient can claim responsibility for. Previous surgery, which is you develop scar tissue from those surgeries, and the scar tissue forms a band across the small intestine somewhere, and occasionally it kinks around this band. That's the most common cause. We also see this condition occur with cancers, and then surprisingly enough, the next most common one is with hernias. You could have your small bowel pushed through a hernia in the abdominal wall or down in the inguinal area, the groin area where men commonly develop hernias, and the bowel can push through and then get stuck and then swell, and it can become impossible to reduce, and it blocks off the intestine. Those are the 3 most common causes. Treatment frequently is bowel rest, IV fluids. Hopefully the swelling goes down, it unkinks and reduces, or in some instances, we have to have urgent surgical referral, and the surgeon has to relieve the obstruction. We don't see a whole lot of large bowel obstructions. The condition that I would say affects the large bowel most commonly would be a condition called diverticulosis, and the infection cousin of that is diverticulitis. So diverticulosis is a condition where, as we age, we get less elastic, and particularly if we're those people who don't have a good, healthy diet with lots of fiber and a healthy microbiome, we start to see increased pressures in our large intestine that start to cause little blowouts or blebs in the wall of the colon that we call diverticuli, little outpouchings. These diverticuli can become infected, probably not nearly as much an issue with nuts and seeds and popcorn as we once thought. That's probably not a thing. It's just having diverticuli, something that is basically determined at the time of colonoscopy, which should be done at age 45. If you've got no family history, should be your first screening colonoscopy. If that initial one is negative, and by the way, it used to be 50, so keep that in mind. If that initial one is negative, you're looking at screening every 10 years. So anyways, these diverticuli can become infected, a condition called diverticulitis, generally fairly easily treatable with oral antibiotics, depending on the severity of the symptoms and perhaps maybe what your lab work might look like. We might do a CAT scan to be sure you haven't developed an abscess, which wouldn't treat well with just antibiotics and might need surgical drainage. You can bleed from diverticuli, so you can have lower gastrointestinal bleeding. With lower gastrointestinal bleeding, bleeding from the lower small bowel or the large bowel, the bleeding will be bloody, not black and digested. I will tell you that just like you can have a heart attack and kill off tissue in the heart from a blockage in an artery that feeds that muscle, you can have a stroke and block off tissue in the brain from an artery that feeds that important organ. Your gastrointestinal system has its own blood supply, and it can be blocked by atherosclerosis or other processes. We talked about embolic phenomena from atrial fibrillation, where your heart throws a clot and it goes somewhere. That's what killed my granddad. He had what was called small bowel ischemia. Very unfortunate occurrence. He had his gallbladder out. He was having a lot of abdominal pain afterwards. They attributed it to an old man who couldn't handle the pain, but he had chronic atrial fibrillation. And he was not anticoagulated, and it was found out too late in the game, where he had too much dead bowel for a guy in his 80s to survive. And they figured out he had blocked off one of the large mesenteric arteries to his small intestine, and he killed a bunch of small intestine, which rotted inside his belly and killed him. So you can have vascular disease of your intestinal tract that can also cause abdominal pain, and that's on the differential when we see people with abdominal pain. That type of pain is typically also painful after eating, so it could mimic a gallbladder. So abdominal pain is a complex diagnosis for the emergency room physician to have to wade through each and every time. And I've got almost 30 years of experience of doing so. We kind of discussed inflammatory bowel disease in autoimmune diseases, and of course inflammatory bowel diseases can affect the intestines, small and large, depending on which one, can cause lower gastrointestinal bleeding or hemorrhage. Hemorrhoids are at the end of the game. That's something that can cause bleeding. Internal hemorrhoids are on that same pathway of like varices, the end of the portal system, and external hemorrhoids actually can be caused by straining. And I had one of those one time, helping a guy clear some land and carrying 6-foot chunks of birch. And generally an external hemorrhoid is pretty painful. Internal hemorrhoids are not. When you have an external hemorrhoid, you will probably note a bump that will be a little tender if you mash on it. If you get to that quickly enough and it's large enough, an ER physician or a general surgeon can numb that area and cut a little piece of tissue out, pop the clot out, and then you can just use some topical analgesics or pain discomfort medications and allow that to heal. If you let it go for too many days, you just got to let it resorb. You end up with a little tag, a hemorrhoid tag. No life-threatening deal there. I think that's covered what I wanted to cover on the gastrointestinal system. There's a few behavioral things to think about, so hopefully that'll help you guys to avoid unnecessary self-damage. Again, most of these things are, you kind of got it, and that's too bad. But don't forget, when you take your anti-inflammatories, make sure they land on food. Don't consume too much alcohol. Try to watch your weight so you don't get a lot of gastroesophageal reflux disease. And anyways, it's great to talk to you guys. I hope that this has been helpful in explaining some of these typical processes and problems that occur in the human body that us ER doctors get to evaluate on a regular basis. And we're going to move on to kidneys after this. And then, like I said, final will be frailty. I'll teach you how to avoid that so that you can expect success. Thank you very much.